different to everybody else has said. So yeah, I work at the Trust as a mental health nurse, and I'm also Unison rep as well. So if I say anything controversial, I'm speaking on behalf of Unison. What I will say is that staff are continuing to do their best in times what is kind of feels pretty impossible. I was going to talk a little bit about funding, because dear old Norman keeps trotting out parity of esteem. I thought maybe one of the things we could do to raise funds for the campaign would be to come develop some Norman Lamb bingo cards. So when he's on the radio and you hear him say, outrageous, unacceptable, parity of esteem, crisis care concordat, something like that, you can tick it off. You can tweet off Facebook, bingo. But to be serious, so parity of esteem, we know around 23 to 25% of NHS need is mental health. At the very least, from what Danny said earlier, that's probably underestimated. So what's the situation locally? How much do our clinical commissioning groups, those people who decide how much money to give our mental health trust to provide services, give? Nationally, the range is between 6% for the worst trusts and 18% for the best. The national average is 10. So we're already starting from a low baseline. So let's start with Norman's own constituency, North Norfolk. North Norfolk Clinical Commissioning Group allocates 9.09% of funding to mental health. It's good to see that Norman is having such a positive impact on commissioners in his own area. West Norfolk, 7.8%. Norwich, the best of all of them, 13.49%, which is significantly better when compared to what the need is still woefully short. South Norfolk, 8.59%, Ipswich and East Suffolk, 10.7%, and West Suffolk, 10%. So if you imagine, even if all of the other clinical commissioning groups funded our services to the same extent as Norfolk, would we still have had to make the cuts that have been imposed on the trust? Coupled with NHS England, who imposed worse cuts on mental health trusts compared to physical health trusts. Even our own Chief Executive, Michael Scott, said last week that if we'd been funded the same way that acute physical health hospitals have, we'd had about another £30 million a year in our budget, which would actually cover all the cuts that have been made. So I guess, like, as everyone's been said, we're pretty fed up of Norman Lamb declaring himself furious and acting like a campaigner rather than the Minister of State that he is. And if he really can't do anything about it, he also forgets he's furious with NHS England because they've done this autonomously and the government don't have any control over it. But he voted for the Health and Social Care Act and paid for it that gave him that power. So if he feels so strongly about it, and yet as a minister we can't do anything about it, if he had any principles, then he should resign. So where are we? I was lucky enough, along with Mark as well, to speak at the first meeting that launched the campaign. 1 year on, still no accountability, lots of hand-wringing, everybody saying how terrible it is. But the system's been set up like that. The Health and Social Care Act, there's no inbuilt accountability. The CCGs are saying, well, we're doing what NHS England have asked us to do. The Trust is saying quite rightly, our budget's been slashed, we've tried to do the best that we can. And Norman goes, nothing to do with me. So that's that. I was going to do, some of you have kind of come to the campaign later than others, so I was just going to do a little bit of a timeline, a reminder of everything that's happened so far. As far back as January 2013, we wrote to the Care Quality Commission, who obviously are responsible for the quality and safety of services, to say, we don't have enough beds, there's a crisis locally, we think you need to take urgent action. At that time, December 2012, our bed occupancy was running at 115%. That's back then. If you make these cuts, this situation is only going to get worse. No action. Then in March 2013, we went to Health Overview and Scrutiny Committee to give evidence to our response to the proposed cuts. We made a number of warnings, and it gives me absolutely no pleasure to say, I told you so. But we said, cutting staff like this means that there's going to it's not going to be safe, so we're going to have to waste money on temporary staffing, which is exactly what has happened. £2 million a month is being spent on temporary staffing. And month on month, it's shrinking. How much is going to NHS professionals, NHS Bank, and how much is it going to private nursing agencies and locums. Also bringing in staff, if you look at why morale is so bad as well, bringing in staff who are sometimes being paid double per hour what their NHS colleague who's been working through this has been paid. We said it's unrealistic that social care and the voluntary sector are going to be able to pick up the slack and just work in partnership better, because their budgets have been slashed as well. That's exactly what happened. March 2013, we said morale is really low and staff are distressed at the poor service they're being able to give. This will get worse if you implement these cuts. We also said the transitional funding proposed by the clinical commissioning groups will not be sufficient to mitigate the risks. But the evidence given back by the Trust, which is in the final report, I reread this today from Norfolk and Suffolk Scrutiny, said, NSFT has said that although there is a desire for fewer admissions, there will always be a bed available for service users who have a clinical need for them. What they didn't say was that might be in Brighton or London or Weston-super-Mare, and actually you might not even be lucky enough to go there in an ambulance. You might be sent their case in the back of a police van, which has happened. So I've got so many notes here as well. So we see this as it's a human rights issue to criminalise and treat people and send them around the country like that. It's also against the best evidence base. What we're basically saying is that we can afford not to follow the best evidence, but to go back to what we were doing a few years ago. Just imagine if in cancer care, well, yeah, we know what the best treatment is, but our budget's been cut. So what we're going to do is we're going to give you what was the best treatment 15 years ago. It wouldn't be accepted. So it must be an issue of stigma that they're treating people who need mental health care in this way. Some of the changes that have been made not just go against the evidence base, but they go against what is in Norfolk's suicide reduction strategy. It's a county-wide strategy that was from 2011 to 2014, which the Mental Health Trust was part of contributing to the development of that strategy, which says local mental health services will continue to target specialised support to homeless people and those in temporary accommodation. Well, the homeless team was one of the teams that was cut completely as part of the reorganisation. So we've even gone against our own local policy. We're just going to finish with a couple of quotes from another report and see how it kind of matches up locally. So, the finances and the associated staff cuts were being made in an organisation which was already identified as having serious problems delivering adequate quality. We will sit locally that we were already raising concerns as early as January 2013 that we were already creating. There was a tolerance of poor standards and a focus on financial target and the denial of concerns. You'll be aware for the first, well, months, we had senior people in the organisation trying to discredit what we were saying as a campaign and what we were saying as unison, saying the so-called beds crisis. When we said that there were 200 people in the community that didn't have an allocated care coordinator, we basically were called liars, live on the media. Said it was only 98, well that's all right then, but it wasn't. And then all be allocated by November 2013. Well, here we are a year on and that number actually got up as high as 400, and it is still hundreds. We've not had an apology for being called a liar either. There was a culture of self-promotion rather than critical analysis and openness. It took false assurance from good news, yet tolerated or sought to explain away bad news. We've had lots of that trying to explain or kind of play down what's going on. Staff and patient surveys continually gave signs of dissatisfaction, yet no effective action was taken, and the board lacked awareness of the reality, most likely due to the lack of importance that they accorded to those sources. Just to give you some snapshots, you'll be aware, I'm sure you've seen, that our trust came out worse in the National Survey of Mental Health Trust for staff morale. The CQC got very poor results from what they asked. Does anybody know which report I was quoting from? Francis. Yeah, the Francis report into Mid Staffordshire Hospital. So I'm going to leave you to think about that and what we're learning, if anything, from history.